So it's gonna be a surprise. And so I pass the mic to Gabriel.
Yeah, hi everyone. My name is Gabriela. I'm from Peru too. And talking about sweets, actually, it was my brother's birthday, and we ate a lot of sweets. And now we're celebrating at the beach his birthday. And about the surprise, it's the launching of the Spanish CP Solvers website. We were translating. We have a mission to translate all the schemas and illness script to Spanish. And it's one of the main reasons I love CP Solvers. Its mission to democratize the knowledge to all the world, and I love that.
Amazing. I will reflect on that in a moment, but how could we not have the one and only Kiara say hello, one of the leaders of this project?
Hey friends, I'm so happy to see you today. It's been a while for me. Just about our project, I'm Jime Vale, and we and Gabriel. We are also excited because we've been working for a couple of months on this project about, as Gabriel said, democratizing clinical reasoning, but in our language, which is Spanish. So now we have created some schemas. Then we're planning to keep translating illness scripts and some videos into Spanish, so it can be useful not only for our Spanish community, but for all of you, our friends that belong to this amazing community. So we can use that for keep learning, for teaching, for will be helpful for treating our patients and everything. So we're so excited, and you will be able to see our work in a couple of days, probably.
Tomorrow, to be more precise.
Yeah.
Y'all, they've been doing absolutely unbelievable work, and I cannot wait for you to see it. It's just when all you have to do when you have brilliant people is to step out the way. And Maria, Chiara, Vale, Gabrielle, and with the input of many others on Twitter and so on, and help of the website team and CP Solvers, just so many people go into this work, and they're doing absolutely incredible stuff. And the goal is to try to do this for every language, but we're starting from somewhere, and hopefully we'll be able to do more and more and more. My dear friend Amanda has a case for us. She says it's a simple case, but I trust everything she says except that, because she has had many fascinating presentations before, so we should all be on guard. Amanda, do you want to say hello?
Hi everyone, I'm so happy to be here today. And it's a simple case, but not too simple. It's an interesting case. I'm here with my coffee, and I'm so happy and excited to present this case.
I've always wanted to ask you, how do you make your coffee?
My coffee is a strong coffee because I need some energy, and it's no sugar and so strong.
No sugar, huh? Wow.
No sugar.
Okay, but where do you get your bean? What kind of coffee do you have?
So in Brazil, we have a coffee like it's in capsula. I don't know how to say capsula.
Say it,
And yes. And I had a strong capsule with the more strong possible, and they have the coffee and no sugar. It's simple.
Can I ask you, do most people have no sugar in their coffee, or is this just you?
No, it's just me.
Okay.
No, it's more commonly sugar in the coffee, but I like no sugar.
100%. Keep Tiago employed with some sugar in the coffee,
Mm-hmm.
All right, y'all. Are you ready to do this together?
Yes.
Amazing. All right. All right, we're ready wherever you are, my friend.
So let's start. In the chief complaint, we have a 77 years old male comes to the ED complaint of headache. So
Why don't we stop there? You know, there's a lot to think about. Is that okay with you, boss? Amazing. I think it's going to be hard to talk about headache because Kushal is dying on a hill, and the hill is the following: coffee with no sugar and pizza with pineapple toppings. Amazing. Okay. Imagine that you get a headache after you have coffee with no sugar, or your patient who's 77 comes in with a headache. I'm curious how folks are thinking. What are the first thoughts that flow out of your mind? And I'll mute for 30 seconds to a minute, and we'll try to get everybody away from the pizza to the headache. All right, let me know what you're thinking, okay? 1 minute. All right, keep the thoughts coming. Alex, tell us what you mean by that.
Hey everybody, good morning. So I guess one of the first things I think of is this somebody who has headaches regularly and has potentially a primary headache process? So like migraine headaches, cluster headaches, tension headaches, or is this somebody who has some other systemic process going on that could be causing their headache? Like are they hypoxic? Did they just experience a trauma? Are they having facial pain, dental pain, or neck pain that could be referred to their headache? And then I guess other things, if I were seeing this patient live for the first time, say in the ED, for example, I might want to think about like a acute do not miss diagnoses. Like was this headache sudden onset? Might we be thinking about some type of intraparenchymal or intracranial bleed? Those were just a few thoughts I had.
Absolutely brilliant. They stand by themselves. Thank you so much. Ines was talking about a little bit more about primary headaches. Can you tell us more what you're thinking about? I don't think they've unmuted themselves. Okay, in the meantime, Ines, if you have time to tell us more about what you were thinking, please do. In the meantime, sorry. In the meantime, Kiara was talking about intra versus extracranial. Can you tell us what you mean?
Yeah. So extracranial can be something not exactly related with brain. So this can be like otitis media or some dental abscess or something that is causing headaches, pain, or for example, trigeminal neuralgia. I don't know how to pronounce it in English. And intracranial can be anything that is causing inside, like brain injury, like an abscess, neurocysticercosis. I'm not so sure if intracranial can be like giant cell arteritis, migraine, which is more very common, etc.
I think that's absolutely superb, my friend. Carolyn, you were talking about the Snoop mnemonic and the time course. Do you want to expand on those?
Hey, sorry, I'm with my kid. I had the kid in a different room. She's very upset right now.
Oh,
So yeah, I mean, I just, the onset and the time course, I think will be important. I looked up the Snoop mnemonic. I had never heard of it before. But, you know, again, just alarm symptoms. How long has this been going on? Type of sudden onset, things like that.
I love it. Yeah, I think in the chat you outlined the SNOOP stands for systemic symptoms, neuroscience, onset, older age of onset, and prior headache history as all features to help us understand whether the headache is more or less concerning. Gabby, do you want to tell us more about what you just said? I think it's very helpful.
Yeah, great discussion. I was going to say that there are 4 types of primary headaches, and there are migraines, tension types, trigeminal, autonomics, and other. So you said about cluster headaches, and cluster headaches is one type of the trigeminal autonomic headaches. Other types are episodic cluster headache and chronic cluster headache, paroxysmal hemicrania, short-lasting unilateral neuroidiform headache attacks, and there's a lot of other SUNCT and SUNA and hemicrania continua, and the fourth type are the other types of headaches, which are primary cough headache, cold stimulus headache, and any other types. And I would like to say that you have to exclude the secondary causes to diagnose these, especially the other primary headache disorders, because, for example, the primary cough headache, when you have a headache with cough, this is a red flag. So you have to investigate, and if you don't find anything, this will probably be a primary cough headache.
Super, super helpful. Riley, you're telling us that there's the P mnemonic stands for something else. Do you want to tell us more?
Yes, I think the P can have a lot of, because I think it stands initially for pattern changes. And so either, or triggers like position, changes in position, like paroxysmal headache, or by exercise. We also had a case weeks ago about, I believe, carotid aneurysm that was, or a vertebral aneurysm that was triggered by exercise, and also Valsalva maneuvers and the presence of papilledema, which I think is a really important alarm sign, just thinking about intracranial hypertension.
I think that's beautiful. I really do. Thank you so much for sharing it. I think at the end of the day, if I were to summarize what everybody's saying, is when somebody's head hurts, you have to try to understand whether there's identifiable pathology or not. You cannot see, feel, or image or blood test any of the primary headache syndromes. They're diagnoses of exclusion primarily because we don't fully understand what causes them and cannot definitively diagnose them. There's no way that the diagnostic certainty of migraines is as good as a diagnostic certainty of an intracranial mass, because a migraine is diagnosed through a conversation with a patient, which has much more of a error rate than an MRI to look at a mass. So the first branch point is, as Mario was saying in the chat, primary versus secondary. Primary being the outstanding discussion that you should listen to by Gabby breaking it down. And then secondary, I think that's where Kiara's point is really important. Secondary headache syndromes, meaning that you're going to find a very specific entity in your evaluation, is usually in the head, i.e. intracranial, but sometimes outside the head. Things in the eye like glaucoma, things in the face like herpes zoster, and things in the body like really bad influenza can cause a devastating headache without actually having problems in the brain itself. And the thing that I will layer on is to suggest further classifying secondary intracranial headaches into the following 4 categories. Is the intracranial headache originating from the parenchyma, like a mass? Is it originating from the ventricles because of obstructive hydrocephalus? Is it originating in the vessels because of vasculitis, dural venous sinus thrombosis? Or is it originating in the meninges because of meningitis? So I break down the secondary intracranial component into parenchyma, ventricles, vessels, meninges. Why? The parenchyma you image with CT or MRI. Ventricle is the same. Vessels you have to think hard about, because you may need to do a biopsy of a vessel outside the brain. You may need to do a special MRI with the dural venous sinus thrombosis, the MRV, or you may need invasive angiography to diagnose it. So how you approach the vessels is very different. And the same with meninges. You can see clues of a meningeal cause on MRI, such as a meningeal enhancement, but you need an LP. So I break them down into parenchyma, ventricles, vessels, meninges to give me guidance on how I might make progress and to use the conversation with the patient to try to localize it within one of those compartments. So if somebody has headache and neck stiffness, I'm worried about meningitis. If somebody has headache and elevated intracranial pressure, I worry more about the parenchyma and ventricles. If somebody has as evidence of vascular involvement elsewhere, for example, in a recent VMR, we had headache and ischemic fingertips. And in that case, the ischemic fingertips are a vascular phenomenon, and it turned out that the headache was also a vascular phenomenon. So by dividing them into those 4 compartments, you are at an advantage for 2 reasons. It informs the diagnostic testing, and it allows you to talk to the patient and study your analysis and marry that analysis with where the lesion is. Again, parenchyma, ventricles, vessels, meninges. And I think that's the question now is this primary or secondary? And the age of the patient is concerning for secondary. And if it's secondary, is it intracranial or extracranial? And then when intracranial, is it parenchyma, ventricles, vessels, meninges? And so if we try to do that exercise with the information that that Amanda gives us next.
So the patient reports that he had feeling a continuous holocranial headache for 10 days, denies triggering factors or irradiations, accompanied by asthenia and vomiting food for 5 days, and also reports that in the last 3 days he had difficulty for walking and have a fever that was not thermometed and improved with paracetamol, denies diarrhea, weight loss, or recent traumas. In past medical history, he had hypertension using losartan 50 milligrams and amlodipine 5 milligrams, uses sertraline 25 milligrams, non-allergies or recent surgeries or travels. So in meds, losartan, amlodipine, and sertraline, and his father died of heart attack, and his mother has hypertension.
Super helpful, Amanda. All right, folks. So let's study this data together. I'll mute for a minute and keep your thoughts coming, okay? Carl, tell us more.
Hey, yeah, sorry. I think as kind of the group was attuned to at the beginning, I mean, yeah, this gentleman is 77 with no headache history and now has this relatively acute onset of not just a headache, but a headache with some concerning features. The vomiting in particular could be a sign of like increased ICP. The subjective fever, obviously, we need to, could be a potential sign of infection. The difficulty walking could be true weakness or it could be just kind of asthenia, but we obviously need to tease that out. That's all I got.
I think that's absolutely amazing, quite honestly. Perfect. I love how concisely you said it. It really hit the nail on the head. Vale, you were counting the number of red flags prompted by Gabby. Do you want to just tell us what they are for you? Like if you were just to say you're talking to a first-year medical student who's just beginning to understand them, how would you just list the red flags?
Okay, so I'm gonna try. I was thinking of, well, actually 4 just because of the age of the patient.
Yes, yeah.
Then vomiting as a sign of intracranial hypertension, difficulty walking that as Carl mentioned, could be a focal neurological sign, and the fever.
Beautiful.
Those were my signs.
Amazing. Let's cross-check them with the expert, Gabby. What were your 4?
Yeah, I can't, there's nothing I can add. I would just Actually, I would like to say something that the duration of 10 days, if this is a continuous headache, if the person doesn't have like any minute without a headache, this can also be a red flag because this can mean that the headache is progressive, I think. But also some headaches are very short, like the trigeminal autonomic. So if the duration is too small, this can also be a red flag. But I agree with you.
That is, I'd never thought about that. Like, it just not even a minute without the headache is a important thing to pay attention to. Really, that's the high level pearl that you only get from people like Gabby. I've never seen that in a textbook or anything. Thank you so much. Kushal is getting practical. So Kushal, tell us what you're thinking.
Yeah, I was, whenever I see fever, I think of inflammation and infection, infectious causes of headache. So when we consider that, we always have to check for the immune status. So whether the patient is HIV positive or negative. I would also check for pets, even birds like Chlamydia psittacia can cause headache, present with headache. If there is bird poop, then cryptococcal meningitis can happen. The other thing I was thinking was CNS Chagas. I'm not sure what's the incubation period for that, but if patients living condition where they live in like a hut or something like that, where they have vectors, triatome bugs, they can get from that. So those are the things I was thinking of, and but I agree that this can be anything at this point, and the differential should be broad at this point.
Beautiful. I absolutely love that. Nothing to add. And Anne-Marie, you were invoking the fever and reminding us of that dimension of this case. Do you want to just expand on your thoughts in the chat?
Yeah, so adding the fever onto this, I guess it could be like a toxidrome or something like that, but I'm going to make the assumption that there's probably inflammation there, which from the CP solvers, we all know that I made mnemonic, thinking about it. So like, could there be infection, malignancy, autoimmune, drug or endocrinopathy? And just like kind of thinking through all those things and then layering it onto the other symptoms.
Oh, I absolutely love it. Nothing to add. All right. Favor from you all. So I see Gabrielle has a problem representation. So can I ask Gabrielle, can you give us your problem representation in Spanish? And maybe I'll ask Rafa to give the equivalent in Portuguese.
Sí, bueno, este es el caso de un hombre de 77 años que se presenta a la consulta por dolor de cabeza ucraniana de duración de 10 días y con factores de riesgo por sospecha de meningitis.
Amazing. Kiara, how do you do? Because I have no idea.
How do I what?
How did he do? How did our friend Gabrielle do? You give him A or A+?
A+, and success A+ too.
Amazing. Thank you so much, Gabrielle. Rafa, you're up, my friend.
Ok, então esse é um paciente de 77 anos que se apresentou com cefaleia holocraniana de duração de 10 dias. Ele referiu que não tinha nenhum fator que precipitou a dor de cabeça e nem que ela se irradiava. Esse paciente, ele referiu que associado a essa dor de cabeça ele tinha astenia, vômitos de duração por 5 dias, dificuldade por andar por 3 dias, e uma febre que subjetiva, provavelmente não foi ferida, que melhorou com o uso de paracetamol. Esse paciente, ele nega diarreia, perda de peso ou trauma recente. That's basically it.
Amazing. Gabby, how do you do? He was picking on you in the chat, so this is your chance.
Yeah, he was great, of course, as always.
As always. I love it. I love it. Thank you both so much. Let's try to keep updating that PR. So I'll come back to you all with every aliquot to see how we're getting closer and closer and closer to the answer. You know, I honestly have nothing to add. I think the chat is zeroing in on the fact that there are features of ICP, and when there are features of ICP, we should prioritize parenchyma and ventricles. If there are features of fever, the most common cause of fever and headache is actually in the meninges. So that if you're just applying base rate, you're like, you know, I'm getting signal for the parenchyma and the ventricles through the intracranial pressure dimension, and then I'm getting prioritizing the meninges because of the fever dimension. But I know you all know or have heard of or thought about the fact that you can get parenchymal or ventricular causes of inflammation, like a brain abscess. Neurocysticercosis is like the most common diagnosis on neuro VMR these days. So those are very possible. But if you're being honest, you're like, elevated ICP, parenchyma, ventricles, fever, meningitis. Can meningitis cause elevated intracranial hypertension? Absolutely. We recently had a case of cryptococcal meningitis with elevated ICP. So I think that it's hard to localize this to the vasculature right now, but you have to be humble because giant cell arteritis, there's nothing inconsistent with this, right? GCA plus a low-grade fever and a headache, totally fair. So where are we? I think we have to be cautious. We have to be cautious. We have to be confident and cautious. I think all of us are confident that there's a secondary cause of headache at play here, but I think you have to be cautious about which compartment you're dealing with. And so I'd keep an open mind, and maybe the exam will help us be more confident about ICP. But at the end of the day, how do we sift through those four possibilities, parenchyma, ventricles, vessels, meninges, is you knock out the first two. You get an image, either a great image in the form of MRI or a good image in the form of CT, and you look for those as the possibility before you move on to vessels and meninges. All righty. Amanda, back to you for this very simple case.
So in the exam, we have a BP G 108 over 80, and heart rate is 80 BPM, respiratory rate is 21, SATs is 96% on room air, and fever at the times of the consultation is 38.8 Celsius. And Jen is unwell and confused. The HEENT, pale and dehydrated mucous membranes, tuberculosis, cardiovascular and pulmonary are both normally, and abdominal present of vital signs, no visceromegaly. In the neuro, slow talking and nuchal rigidity. In the extremity is skin without chains.
Amazing. Do you think you could give us this, because of the time, maybe just the first set of labs?
Of course.
Thank you.
Então, the labs, the WBC is 25,000 and bends it's 11%, neutrophils is 77%, lymphocytes is 9%, platelets is 200,000, hemoglobin is 10.6, sodium is 138, potassium is 4.7, chloride is 95, creatinine is 1.3, and glucose 95, PCR is 95, and ALT is 40, AST is 35, alkaline phosphatase is 90, albumin is 5, globulin 3, and total proteins 8.
Amazing. Whew, there's so much here, a lot to digest. So I'll unmute and please keep your thoughts coming, okay? Amanda, I think Rafa was curious. Was there nuchal rigidity? Was there neck stiffness?
So it's the nuclear rigidity. I don't know exactly what he wants to know. So ask me in Portuguese, please.
Se o paciente tem rigidez nucal. Essa era a
Yes,
nossa dúvida.
yes, it's
Ok,
positive.
ok.
Okay. Alrighty, y'all. What are you thinking? Well, let's just do this. Where do you think it localizes? The parenchyma, ventricles, vessels, meninges. What do you think? Yeah, Alex, tell us why.
So I think with both with the fever, the headache, the neck stiffness, the nuchal rigidity, I think that makes the meninges kind of jump out at me, and especially with the very high white blood cell count, I'm concerned for some type of infectious process. We have apart from the difficulty walking, we don't necessarily have any. We don't know yet if we have any like strict neurologic deficits. It's been kind of difficult to examine this patient given the confusion. So could this be a process that's involving the meninges and the parenchyma itself? Definitely, but I think there's no question that the meninges are likely to be involved in and of themselves.
I couldn't agree more. I think Tiago is teaching us about the sensitivity of meningitis. You want to tell us more, Tiago?
Oh, yeah. So I just Googled it because I had something in mind that it was not as high. And it looks like the sensitivity is about 30% and the specificity is about 68%. So do not take it seriously because it was just a Google, but it's not something, yeah, it's a good parameter, but don't just bear on it.
100%. I agree with you. I think that we've seen many patients with meningitis who don't have neck stiffness. In fact, we see patients with meningitis with not even a high white blood cell in the CSF, with Cryptococcus being a great example. I'll tell you, I work in the emergency room and everybody's neck is stiff in the emergency room. Everybody. People come in with neck sprains, people come in with vertebral artery dissection, people come in with twisted muscle. So neck stiffness is like just so common that it's very hard to make that leap. But in the context of this case, it's not hard. It's hard to ignore that sign. So I really like that. I think Ravi was asking a very interesting question about the eye movement. Ravi, can you tell us what you're thinking?
Hey, Robbie. If I remember, there was an eye movement test or something, or eye bobbing or something along those lines, that I was told had a higher sensitivity or likelihood ratio, I would say, positive likelihood ratio for meningitis, much better than nuchal rigidity, Koenig and Brzezinski, the classic stuff that would be taught.
Cool, Pearl. I don't think I knew that. Does anyone know more about that, or Ravi, do you remember more or looked up more or anything like that?
Yeah, I remember it, but I was trying to Google it. I don't have. I think it's in McGee's book, if I remember the physical exam book. But I'll try and look it up and find out.
Amazing, please do. I don't think I remember that. That would be awesome. Okay. All right. There's so many thoughts coming in the chat, and I'm just going to try to summarize them. I think Hernan, tell us what you're thinking about rhomboencephalitis. That's a fancy word and a really important one here.
Hi, everyone. Yes, I think the case for me is in the infections category so far. And let's not forget that some bacterial meningitis like Listeria present with a subacute course with rhomboencephalitis that could be the explanation for the walking difficulty, because there is no precision in the information of what kind of walking difficulty there is. Is it because the patient can't move the legs, or is it because he has, for example, a kind of ataxia? So it would be important to precise that. And I'm thinking so far this is a meningitis, and over probability of infection causes, and for a kind of gravity criteria, I would stand for bacterial meningitis until confirmed otherwise.
I absolutely love that. I think you're picking up on the one thing that we should study, which is what is this difficulty walking? And you taught us so much. Is it a motor issue, cerebellar issue, and what that maps onto a rum encephalitis with listeria being very, very important. And Kushal just shared his that he has a schema on his Twitter. For those of you who can't see the chat, his Twitter handle is K_VAISHNINI. He's amazing. He retweets a lot of incredible stuff and also puts out a lot of his own content. So I highly suggest that you follow him and learn from him. So Ravi, do you want to unmute and tell us more? It looks like you've learned more about it.
Yeah, I just found it. It's called the jolt test, so it is exactly what it means. It's jolting the head. I was mistaken. I thought it was the an eye maneuver or something like that. But so the patient is asked to quickly move their head from side to side in a horizontal plane. If there's meningeal irritation, the headache will get worse. If the headache does get worse following this movement, it's an indication for a lumbar puncture. And if I remember the statistics, the likelihood ratio, I think, is way above beyond the traditional Koenig and Brzezinski signs that we have.
Amazing. That's so helpful and so much more intuitive. Thank you so much for sharing that. I'm definitely going to look into it more and more and more. I think people we're zeroing in on what, and I think the real life question is, what do we do next? And I think, I'm no expert in this, so I'd love for Gabby's experience. Gabby, what do you think about, everyone thinks we need to get an LP. Imaging may help us with the diagnosis. But what do you think about, do we need imaging in this case before a lumbar puncture? What are your thoughts about just imaging before LP for the safety of LP perspective?
Yeah, I think you have to do a lumbar puncture if you have, of course, we have to do in this case because we suspect there is an infection. And if you have a suspicion of an increased intracranial pressure, for example, papilledema or a focal neurologic sign, you have to do an image. And also, if we suspect of an abscess, for example, and I'm not sure about this, but I think if the person is confused, you have to do a lumbar puncture as well. Actually, coma is for sure you have to do an image, but I think at least in my residency, if the person was confused, we did image before the lumbar puncture. And just as a reminder, Anne-Marie told about the sixth nerve palsy, and this is a focal neurologic sign, but if there is this, and we suspect, for example, of a crypto, this is not so necessary to do an image before. So this is a focal neurologic sign that we are not so worried about. But I would do an image in this patient because of the confusion. And also, he said he has a difficult walking, so maybe he has mild weakness that we couldn't see in the exam. So I would do it.
Super helpful. Thank you so much. It's very, very helpful. So before we move on and get that data, I think my dear friend Delan shares a great pearl about what else can cause meningitis besides infection. So Delan, do you want to unmute yourself and tell us more?
Yeah, sure. Am I audible?
You sound great.
So, I think a few days back, Ketan presented a case in which the occipital headache was interpreted as a sign of aseptic meningitis. And from there, I picked that headache can also be secondary to meningitis. And it doesn't always have to be an infectious etiology. It can be autoimmune etiology. And CNS vasculitis can cause a meningitis-like picture. And I mean, Sjogren's just came to my mind, and so I put it. But there are also other causes, I'm pretty sure, but I don't recall it perfectly. I'm guessing SLE should be one, but I frankly don't recall other causes of CNS-induced vasculitis-induced meningitis. But that could be a possibility here.
Absolutely. Absolutely. Thank you so much. It's amazing that we've been hanging out for 50 minutes. I feel like we just started. It's incredible hanging out with you all. So Amanda, do you want to just give us all the data right before the diagnosis?
Yes, so I have 2 exams and I give these exams. And the first is the head CT, and the CT scan came normal without change. And we have a cerebral spine fluid. Came with cloudy color, number of cells is 1,200 with 90% of lymphocyte of polymorphonucleases. The proteins is 190, glucose 10, and the culture is positive for Streptococcus pneumoniae.
Wow. Oh, all right, y'all. What do you think? Surprised, not surprised? Is this all done? What do you think? Kushal, you want to tell us more? There's an ID dimension to it. Are you surprised by the answer? Are you confident this is the answer? How do you interpret this? Should we be looking for a reason this happened? Just what are your thoughts?
Yeah, definitely. I'm kind of surprised by the CSF profile, especially considering the duration has been 10 days. I would hope that I would expect patient to be much sicker than the way patient presented. I was hoping for something more subacute etiology, but the CSF profile with really low glucose, protein high, it's just lymphocytic predominance.
Yeah, you know, I never mean to interrupt you.
Yeah.
Amanda actually, I think you mean 90% PMN, right, Amanda? Yeah, it's the other way around. I think it makes more sense. Yeah.
Okay, that makes much more sense. Yeah.
So what do you think? Do you think we need to look for a reason this happened, or what? How do you think about that dimension?
Definitely, because I would definitely look for trigger or underlying risk factors that might have provoked it, because there is no significant past medical history or recent any infections that might have triggered it. So I'm definitely curious what did they find.
I couldn't agree more. Ravi was pointing out that there's another clue that he had a fantastic tutorial about, and that's the bands. Ravi, do you want to tell us more?
Ravi, I'm surprised you remember that tutorial. Yeah.
How could I forget it?
Yeah, that I was very interested. I had a patient with bands with normal white count, and a patient ended up in ICU within the hour within admission. And I kind of looked at the bands of 20,000. I was like, or 20, and I assumed this patient was very toxic, and the patient did truly turn out to be very toxic with MRSA bacteremia in 2 bottles. So I then did a sort of a deep dive into the significance of bandemia in a normal white count setting, and found significant literature that we must not, ignore a bandemia. It could be a portal to look into significant infection in the background. So, patient having bands greater than 10 is thought to be significantly toxic, and we should probe further down the infection sprout. So this patient having neutrophil predominance 77%, bands of 11%, definitely points in the direction, as Kushal mentioned, to a pyogenic infection.
100%. Thank you so much. That's beautiful. Anne-Marie is reminding us to dig deeper a little bit. Anne-Marie, do you want to tell us more?
I was just saying that if someone has strep pneumobacteremia, that's an indication to check for HIV. I'm not sure with strep pneumo meningitis if there's not bacteremia, but I do think that if it's never been checked before, that it's always good to consider immune status and consider checking.
100%. I think that in this case, you step back and you're like, let's be real. The most common cause of bacterial meningitis is the bacteria we have before us, strep pneumo. But you have to remember that kind of teaching is a little bit tricky because bacterial meningitis is so incredibly rare in the modern era. So just because we say the word strep pneumo is a common cause of bacterial meningitis doesn't mean it's rare. It's actually very rare. And so I will tell you, I've probably seen thousands of patients now, 2 years after residency, 3 years into residency. I've never seen this, never. And so I would wonder what the status of the immune system is. And I think HIV is probably the most important one to think out. And then you ask yourself, could it be anything else beyond HIV? And I'll just throw out there that common variable immunodeficiency results in a deficiency killing extracellular bacteria, and is another thing to think about. And I don't remember all the other ones, but remember that adults can get immunodeficiency syndromes. The most common of which is HIV, and then a distant but important second is common variable immunodeficiency, but there are other ones too. So I think that Anne-Marie is reminding us of something very important here. The answer as to why this happened may be completely idiopathic, and maybe because he may not have received the vaccine that protects against this complication, but I think we have to ask it. So I would do a Google search of saying adult immunodeficiency and send an HIV test. So that, I think that is very, very important. Gabrielle is teaching us more about acute meningitis. Do you want to unmute yourself, my friend?
Yeah, I actually was reading the Mandels, that is an infectology book, and about acute meningitis. And in cases of suspicion of acute meningitis, we have to wonder first about viruses because they are the most common cause of acute meningitis. Some examples are enterovirus, HIV, mumps virus, and herpes. Also, we have to consider some bacteria. The first is strep pneumonia, and in some cases, Neisseria meningitis and Listeria monocytogenes. And I think in this case, a patient coming from Brazil, actually wondering about the possibility of Listeria was absolutely correct. Less commonly, there are some parasites such as Naegleria fowleri, as Mario said before. But the thing that surprised me about this case is that actually the 10 days course, because I would have expected that a patient came to the emergency earlier, but maybe the patient didn't have like the opportunity to come, or we have to take in consideration some social factors. I just was wondering about that.
I love it. And I love that you were realistic about it. We could be uncovering something unusual about physiology or pathophysiology, but more likely social determinants of health and social factors influence patient presentation more than anything else. And I think that, I really think that that's a very, very important point. Okay, we are actually almost out of time. So before I pass the mic to Rafa to summarize the teaching points, I'd love for Amanda to kind of tell us what she learned, what the case conclusion was. And then after Amanda's done, I'd love for Vale just to tell us a couple of learning points in Spanish before we move on to Rafa.
So it's a common case, and I love to present. And when we had suspicions of the bacterial meningitis, we started with antibiotics and dexamethasone in the same times, and we wait the CSF. And with the time, the patient had a good response with the medication and have a good evaluation. And it's important to know when we did the CT, the head CT, and when we do the lumbar puncture, Gabby says to us, and is that.
Wonderful. Thank you for presenting a very interesting case. We learned so much from it. Every time you present, I get really, really excited, and today just reinforces that idea. I hope you enjoyed the rest of your coffee if you didn't finish it already. Vale, do you want to just emphasize one or two teaching points that you learned in Spanish for folks listening?
Yes, so algo que aprendí en este VMR fue sobre el test de Holt, que nunca lo había escuchado antes y que aparentemente tiene mejor sensibilidad y especificidad para determinar si es que el paciente necesita una punción lumbar en sospecha de una meningitis de origen infeccioso, a comparación del test de Brudzinski y de Kernick, que es creo que los más clásicos. Y bueno, creo que también lo de la posibilidad de un curso tan subagudo en un paciente de esta edad para una etiología bacteriana, que es algo que no había considerado antes. Yes.
Thank you so much. All right, Rafa, take us home.
First, I just want to say a big thank you for everyone who spent the day with us, especially here in Brazil, it's lunchtime. So, and I just want to thank Amanda for presenting the case and everyone that was here. So we had patients with headache, and we first started with primary and secondary causes of headache. Primary being things like trigeminal, what could be a single set of cluster headaches, much more common in males, which is unusual. We usually expect a headache to be more common in females. Cluster headaches being unilateral with lacrimeation, rhinorrhea. Migraine can also be unilateral with photophobia, phonophobia, and some aura. And tension headache, which is bilateral in a steady band like pain. And secondary headaches, we have to look after causes, etiologies leading to headache. For example, subarachnoid hemorrhage, hydrocephalus, meningitis, neoplasia, giant cell arteritis, glaucoma, zoster, and many other causes. And then when it comes to headache, we have to look for red flag symptoms. There's this mnemonic called SNOOP, systemic symptoms like fever, neurologic symptoms, onset new or changed, also papilledema, pulsatile, tinnitus, positional provocation, or if it's precipitated by exercise. And red flags in this case, we thought about the difficulty walking that could explain like a neuro deficit, the fever, the age, and also the duration. And then we tried to collect clues in this case and trying to combine the nuchal rigidity, the leukocytosis, the altered mental status, and the fever. We thought about infections, for example, meningitis, meningoencephalitis. And then I think the biggest takeaway from this VMR is the JOLT test, because it has MAK status that it actually has a 100% sensitivity for meningitis, and it's helpful in determining which patients with fever and headache need LLP. So we ask the patient to quickly move their head from side to side in a horizontal plane. And if there's meninges irritation, the headache gets worse. And it's an indication for LP, regardless of neck stiffness being present or not. So thank you, everyone. I hope everyone has a good weekend, and I hope to see everyone tomorrow or on Monday.
Amazing. Thank you all. Thank you, Rafa. That was absolutely superb. All right, y'all. Have a wonderful day.